So welcome to the webinar, Digital Denture Protocols, Procedures, and Practice Implementation. The lecture is being presented by our very own Kelly Bevington. And with that, it is my honor to introduce Kelly Bevington. She is the Director of Intraoral Technology. She began her career more than 20 years ago as an RDA EFDA, graduating from Bryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. Kelly has been professionally trained on most major devices, and she is able to provide expert chairside coaching. She manages the NDX Clinical iOS training team and has clinically trained over 1,000 dentists. I think this is higher now, and their teams.
I think so.
Kelly enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And with that, it is my honor to say, take it away, Kelly.
Thank you. Thank you so much, Jessica. Always appreciate the kind introduction. And thank you to all of you for being here tonight and choosing to spend your next hour of your life with us and learning about digital denture protocols, procedures, and practice implementation. So what does that mean? Let's get it moving forward here. A couple disclosures. So I am a full-time employee of National Dentex, and so my salary is my compensation. I do not receive any additional financial support from any commercial vendor partners. And I always like to sort of recap what our learning objectives are for tonight based off of the invitation that you originally read and registered. I know for myself, sometimes I register for so many different educational courses that I lose track as to what it is I'm supposed to be learning about that particular evening. So we're going to talk a little bit about we're going to talk a lot about dentures, but we're going to talk a little bit about understanding workflows for both the analog and digital cases, how best to enhance our communication to the laboratory, and identifying differences between traditional denture production as well as digital printed production, and something I like to refer to as being digitally assisted, where we might combine both a little bit of analog dentistry, traditional dentistry, along with digital workflows. And we'll discuss the advantages and some of the limitations that we have experienced when it comes to our analog and digital protocols. So why go digital? You know, what is a benefit? What we have experienced and what I've experienced working chairside with hundreds of customers, specifically on digital dentures with iTero, is we have higher patient satisfaction, increased efficiency, and profitability through less chair time. So what does that mean? Higher patient satisfaction. I can't tell you when we explain to the patient what is happening next and explain that we are, you know, I've got my iTero scanner, that we're going to take some pictures of their oral cavity versus taking a physical impression. Their eyes light up, they get excited, they've had impressions before, and it was not necessarily a great experience. Increased efficiency. I will say that once you become a proficient user, your time is more efficient versus a physical impression. But it's not going to be the first time you do a intraoral scan of that fully edentulous patient. And then profitability through less chair time. Again, it's very dependable on your proficiency with the techniques in general and your comfort level and how quickly you get up to speed. So as a laboratory group, NDX is very knowledgeable and capable, and I would speak with confidence to encourage you, if you haven't already, to utilize us for digital scans in submitting for prostheses to be fabricated. So we receive over 3,500 scans every day. and I have a mix of scanner names up here on the screen. They continue to grow and change, but to this day, iTero from across the country is still our most received incoming scan. So tons of experience that you can be confident in our knowledge in working with the scans. This is some data that I found on an NADL research paper that Valmont Research had published, and I was a little surprised about it, but I'm into data, so I wanted to share. So this was for 2023, that traditional impressions were still at 65% versus digital at 35%. I see varying data. Usually it's around 60-40, sometimes we can say 50-50. But what I thought was really interesting was the increase by 53% since 2022. So it continues to grow, it continues to evolve, and that's really super exciting. This is the intraoral scanner team here at NDX. So I'm fortunate enough to lead the team, and I pretty much cover the eastern part of the United States. Then I have Brittany Carey. Brittany's a registered dental hygienist out of Arizona, and she covers the western part of the US. And then Brenda Kirkin is a CDA, RDA out of Michigan, and she covers the Midwest. What I'm most excited about all of us and what we can provide to you is we are professionally trained dental professionals. We're not salespeople that learned a little bit about a particular scanner. We understand dentistry very comprehensively, and are eager and capable to share that knowledge with you. So let's talk a little bit about challenges and successes as well. So we're going to sort of go back and forth a little bit between analog dentistry and digital dentistry, specific when it comes to dentures. And so what are some of the negatives or challenges about analog? Oftentimes there's multiple try-ins. Oftentimes there's multiple adjustments to the final denture once it's delivered. Back in the day, the dentist I worked for would be like, I'm going to be married to this patient for the rest of my life. It's a common theme out there. Tooth delamination. It's a thing, right? Sometimes a denture tooth will pop out of the denture. It's exciting to see that that's no longer a concern when it comes to the printed digital dentures. And then on occasion, there's some breakage, right? Somebody drops their denture in a porcelain sink, or from a higher level in a shower or a tub, or they lose their denture, or dogs have eaten dentures before. So several different challenges that you eliminate when it comes to digital. Or if you're not eliminating it, you're making the refabrication process much smoother. So if you lose a denture or break a denture because of dropping, you can have it reprinted. So we have a 5-year warranty, as well as holding the file for 5 years so that it could be reprinted as needed. Honestly, I would recommend saving those. I mean, I know they're on your myitero.com web-based platform, and I would make certain that I have ready access to those STL files as well. So some of the advantages of a digital workflow is a more precise fit, superior bonding procedures, and that's through the chemical adhesion of the printed denture tooth to the printed base, superior strength, preserving the denture file, which I just briefly mentioned, and consistency and continuity. So the image here, the CAD/CAM image with the more darker green, you can see to the bottom right, that green indicates a tighter surface fit, right? Whereas a traditionally packed and pressed acrylic is far less retentive, would be the best way to say it. So we're going to talk a little bit about what those workflows look like as far as fully edentulous scans and as far as a reference denture. I'm also just threw in more of a little teaser, some images on facial scanning, because we're doing a brand new presentation in January that I'm super psyched about, working with some technicians within NDX, and facial scanning will be part of that. So digital dentures and a 3-appointment digital denture. So as a company, right, NDX has had great success with the copy denture workflow. And what is a copy denture? A copy denture is an exact copy of an existing denture. The tooth shade could be changed up, but it is, it's an exact copy. So it is the patient that comes into your practice, and they have this denture. They love it. They love everything about it. They're going to be traveling this winter. They're going cruising, and they want to back up. They want to spare. That would be the definition of a copy denture technique, and we're going to discuss that in greater detail. A reference denture, on the other hand, is a patient that comes in. They have a denture, so that's great, but it doesn't really fit well anymore, and it might be broken, and there might be teeth that are chipped off, and we're going to take an impression inside of that existing denture. More to come on that, but think of it as the best custom tray you could ever imagine, right? It's the best custom tray. And so oftentimes I work with dentists who their mindset needs to shift a little bit from not wanting anything to do with that old denture. We still want to use it. We want to use it as that custom tray, and we want to use it to assist us in verifying a good solid video. And then the immediate denture. So what's an immediate denture? An immediate denture is a patient that has some existing teeth. You're going to scan both the maxillary and mandibular arches, get a bite registration, and then you're getting a denture back at that appointment when you are extracting the teeth as well. Lots of success with the immediate denture, lots of success with the reference denture, lots of success with the copy denture. The fourth option would be the fully edentulous patient scan. And I'm going to get to that in just a little bit. It's not quite 3 appointments, in my opinion, because we should probably add in a base plate and bite block to assist you in verifying video. Really creating, or taking the measurements to provide to the laboratory what vertical really is. You could do a mush bite as well. Most dental laboratories don't get really excited about receiving mush bites. I'll be honest with you on that. But so let's get back to our data a little bit here. So there are 23 million fully edentulous people, 12 million per arch, in the US. I mean, isn't that amazing, right? 90% of those edentulous patients have an existing denture, which is awesome, because that's going to lend itself well to the reference denture and taking a wash impression inside the existing denture. So a little tip or a little pearl would be to encourage that denture patient to remember to bring their old denture, even if they're not wearing it on a regular basis. There's something about it that they don't like. Still bring it in, because there is probably great value in you using it as that custom tray. Now, 15% of dentures are replaced every year. 81% of patients are dissatisfied with their dentures. Isn't that amazing? 81% of patients are unhappy with their existing denture. So what an opportunity for all of the dentists, all of the clinicians out there that want to provide that as a procedure that they offer to their patients. And so that indicates that there's 174 edentulous people for every GP out there in the US. That's quite a patient base, right? So doing the math, 52.2 million arches of dentures are in the US right now. Currently 7.83 million are replaced yearly, with 42.3 million arches that could be replaced because the patients are dissatisfied. And, you know, when it comes to insurance reimbursement, oftentimes, but as far as recommendations, dentures should be replaced approximately every 5 years. And in contrast, think about single unit crowns and implants. So there's 2.3 million single implant crowns and about 31 million single crowns placed annually, right? Sort of like the offset of that. I thought this was really interesting. One of my coworkers was kind enough to share the math, share the data. Occlusion and dentures, it's important, right? It's important. I can't tell you how many practices I go into and they want to take just a upper scan and a lower scan and send it to the lab and tell the lab to do a setup for try-in. And there's no conversation about vertical. And no reference, no measurements, nothing provided. So the more communication you can provide upfront to the lab, the better result you and your patient are going to have at that try-in appointment. So talking about measurements and so forth. So we've got a Boley gauge here to the left-hand side. I'm sure all of you, if you're not currently using it, remember it from dental school. And then this little gizmo to the right is a, see if I pronounce it correctly, Cometior, Cometior. There's a couple different brands out there. Look on social media. It's all over the place on Instagram, which is where I noticed it. And it's available on eBay and so forth too. So it just is not just, but it provides you a tool to be able to provide to the laboratory appropriate measurements for not only your bite, but the shape and mold and size of your teeth as well. So we all know what this is, right? Alternate impressions for cast models, immediate denture, right? Some pre-treatment scans, one in black and white, one in color. You want to make sure that you're capturing all of your anatomical landmarks. Lip and cheek retraction is really important, and there's many different items out there on the market right now. So what you see at the bottom of the screen is an Optrogate and a Comfort View. So they're both lip and cheek retractors. They work very nicely when attempting to scan the fully edentulous intraoral patient if you're trying to do it by yourself, which I do not necessarily recommend. The image on the top of the screen is something called a ScanMate. A ScanMate is a anti-reflective, autoclavable, soft, flexible retraction device that allows someone else, right? Not the person scanning, but to implore four-handed dentistry and allow that assistant to retract the lips and cheeks while the dentist is scanning. Or maybe it's two assistants. Maybe the assistant is retracting and another assistant is scanning. Every state's a little bit different as far as rules and regulations. But instead of a ScanMate, you could use something like a tongue depressor. A tongue depressor, I might cut a finger off a glove or use a finger cut. Sometimes the wood of the tongue depressor is rough and splintery, so I would be careful with that. But the trick is to retract the lips and cheeks, but not over retract them. And why I say it that way is when we over retract the lips and cheeks and we're capturing the buccal vestibular muscles, right? We're capturing the periphery muscles. We're capturing all of the anatomical landmarks that we need. Sometimes when you get that functional try-in back, there's not as much suction as you would want. And what happens is when you're over retracting those muscles, it's not the same as if when the patient is wearing their dentures, because their lips and cheeks, the muscles are at rest when they're wearing their dentures. So be conscious of that. And it's a fine line, right? You want to capture all of the data, but you don't want to overstretch and over retract the muscles. So what are a few tips, a few pearls for success in scanning the intraoral patient, the fully edentulous intraoral patient? One, I'm gonna load myself up with some 2x2s. I usually have them attached to the patient napkin clip. I also keep them sort of in the crook between my finger and my forefinger so that I can take a gauze, wipe off the tissue, and then immediately scan. Wipe off the tissue and keep on scanning. The drier we can keep the oral cavity, the better the stitching of the individual images will occur. Again, four-handed dentistry, cheek retraction devices may be helpful in being able to really see the tissue that you're trying to capture as well. I do like to mention something called a Dr. Thompson stick. It's a transfer marker. The iTero scanner scans off of topography, not necessarily off of color. So the Dr. Thompson stick is not for it's not for the scanner, it's for you, it's for me. It works well for my eyes, for my brain to digest the information. So when I'm scanning, let's say a maxillary fully edentulous palate, and I'm scanning and I want it to stitch together, if I put some markings, some little X's or like a back and forth, almost like a Christmas tree down the palette, it provides something for my eyes to follow. That's it. It's for my eyes to follow. It's not that it makes a difference with the quality of the scan at all. So you're best served to begin scanning on a anatomical landmark, you know, something that has some topography. So it might be on the maxilla, it might be the rugae, on the mandibular, you know, the frenum. And what's nice is, and we'll get to the RX here in a few minutes, is there's so many great choices, and your ability to turn AI on or AI off. You do want to make sure that you are moving and following in a very steady, methodical, continuous pattern to allow the data to stitch together to the best of your abilities. Really important to keep the lens of the camera clean, right? So you know that with the lens of the camera, with iTero, you want to touch the tooth surfaces. So you want to, you know, touch the tissue, but you don't want to smear debris over the lens, right? So again, keep those 2x2s handy. Even sometimes a pre-moistened alcohol wipe can be very helpful as well. So this is part of your handouts as well. So 3 different handouts were sent to you, I believe it was yesterday, if not first thing this morning. And so these are on part of your handouts as well. But on the mandibular arch, you want to position the wand flat to the midline. And then dip in lingually, capturing all of the lingual data. Sort of similar. I mean, it's still, you know, occlusal lingual buccal, but we're separating it into 2 separate quadrants now. Super important on the mandibular arch that you are capturing the retromolar pad. And then on the maxillary arch, this is actually a good example of what I do with the Dr. Thompson stick too, right? The way I draw on the palate itself. And then you're going to go over the ridge and then finish on the buccal vestibules and do those in 2 halves. And when you get to the midline, you're going to overlap a bit. This is the mush bite that I mentioned earlier, that most dental labs don't get super excited with the mush bite. It can be done well, but it needs to be measured, right? It's there as a matrix. It's there for you to provide information to the laboratory, such as the last bullet point here is allowing the dentist to mark the midline. You can see that marked, to mark the lip line, as well as the frenum attachment. So that's important for the bite registration. And then when you are acquiring the data, right, you're going to take a bilateral bite registration. So you need to be able to cut away some of that mush bite after you take it. You can see the cut mark here. Because the scanner needs to recognize the edentulous maxilla and the edentulous mandible that you captured earlier. That's what the bite registration is combining, right, merging together the maxillary and mandibular scan, whether it be of dentition or of fully edentulous arch. But the anterior part of the mush bite is keeping the patient in line with where you want vertical to be. So we talked a little bit about the importance of capturing those anatomical landmarks, the retromolar pad, the hamular notch. Overextend the capture at the vestibules to make certain that you are capturing the vibrating line as well, where the postam area of the maxillary denture is going to be. That's critically important for adequate retention. And just a couple more images of what those fully edentulous, or partially edentulous in this case, images look like. Another example of that mush bite for a patient that does not have a maxillary denture, and a fully edentulous scan was taken. Or I'm sorry, this is with the analog. So here we have traditional custom tray. You can see it's some border molding occurred. And then the actual full rubber base impressions. So let's shift into the reference denture. The reference denture is by far what we do the most of, what we're finding the greatest success with. So much so, and part of me doesn't like to speak it out loud, but I like to share that this is an evolution, right? 18 months ago, 2 years ago, we weren't even really scanning for dentures because the software wasn't quite where it needed to be able to turn AI on and off and to be able to accurately acquire the data. And now that we can, right, super exciting, the fabrication process at the laboratory is also evolving. And what we're finding is that the functional try-ins are fitting so well that there are, a handful of dentists that I'm working with regularly that are so confident in the functional try-ins that they're going directly to finish. Now, I'm not recommending that by any stretch. I think it's important for a patient to experience a try-in. But know that, in a rush case kind of situation, perhaps, or that might be where we are evolving to, maybe in another 18 months, we'll see that as a possibility. But again, the reference denture is a patient that has an existing denture, and we're going to use that as a template to construct a new denture. Somewhat similar as far as keeping everything really nice and dry. I'm going to go through some of the images as far as what we're looking for on that reference denture. We've become a little less strict as far as, if it had been broken or if a tooth was missing. Initially, we didn't think that would be a good candidate. And we've shifted our thought process on that because truly it has become a custom tray. That's really all the existing denture is. So this denture is in relatively, good shape. It's fully intact. It's not broken. All of the teeth are in place. Mandibular arch, the same sort of thing, right? Everything is intact and looks like it's in pretty good shape. You do want to make sure that the borders are well extended. You don't want them to be real short. You could potentially add some compound stick to it to create a border, to extend it, to then take a wash impression inside of that. That's also an option. If the patient has any type of reline adhesive material, like over-the-counter adhesive, you do want to clean that out and remove it. You do not need to remove a chair side soft reline, only over-the-counter adhesive. And then you will want to apply actual impression adhesive, tray adhesive to the denture before doing that wash impression. And typically rubbing alcohol will remove the adhesive, the tray adhesive, very nicely from the existing denture. So this is an example of the border molding, as well as the mandibular arch, as well as the maxillary arch. Notice how they're taking a blade here to remove the excess. I do not have that on mine. I wish I did. I did not have a blade when I was doing the workshop, but it will make the scanning of this maxillary denture much easier for you, and a more accurate, I believe, a more accurate bite registration as well. Final border molding result, and then the wash impression, right? So preparing the denture, doing the border mold, and then the wash impression. And this is an example of it all done together, right? The reason the bite registration is in place is when you sit the patient upright and attempt to take a bite registration of them wearing their dentures, right? They tend to slide a little bit. So take a little blue mousse or some heavy body impression material and just do a little bit on the occlusal surfaces so that they can, that you can place them into proper vertical, let it set, and then take the bite registration. Couple little tips. You want to make sure that there's no excess saliva inside of the denture itself. Always start on the occlusal surface of the denture teeth, of the cameo surface of the denture. The wand, as with regular dentition, should be flat in contacting the denture itself, and keep the denture stable. And what I mean by that is I'm going to put this down a little bit. I'm going to hold the denture and move my wand, right? I'm not going to hold my wand and move the denture. I hope that makes sense. So hold the denture and move the wand. Many people have asked, and I have tried, can you put the denture on a countertop and scan it that way? I have not had success in doing that. I've tried to even use like sticky tack or something to hold the denture in place, and that did not work well in my hands. It is important to go slow and steady and be very methodical in your scanning. So we talked about, going back and forth between analog and digital. This is, an analog wax bite with similar measurements, right? Wax try-in versus a functional try-in. So a functional try-in is the white material, right, that you see there. So this is, I don't know how well you can really see that up close. The slide's probably better. But it is printed. It's a monolithic puck, and it's all one piece. And you can send that home. You can send your patient home, rather, wearing that functional try-in. Let them try it out. And you can make adjustments to that functional try-in, whether it be the occlusion, you can see to the far left-hand side, that was adjusted. You can take a Sharpie marker and actually draw on the printed functional try-in. So maybe you want the midline shifted, maybe you want to open up the buccal corridors, lots of opportunities there. And another view of that functional try-in. I must say, the first time you take it out of a box, it's a little alarming. It's like, whoa, what is this? So it's good that you're seeing it on screen first. And then when the patient is trying it in, typically their lip line is such that they're still able to get a really good feel for what the final prostheses would be. So we have an analog workflow delivery. I wanted to show you a little bit about the digital denture design and what that looks like in software that we use at the laboratory. So this is design software that we use specifically for dentures. And this is an example of border molding, right? You can see the annotations following the border. So we're like, you've heard of marking a margin. They're marking the border for your dentures here. And then it is converted into a virtual model, if you will. Notice on the maxillary, the post-dam, the butterfly post-dam is put into place. And then they begin to set the teeth. And I thought these were some really cool images to share with you if you haven't had an opportunity to see them. They can move as a set, or they can individually move each of the denture teeth as well in the design part. So the dentures can be designed to be smooth or to be festooned and stippled. I will share with you that's a great opportunity to communicate with your patient and to observe with your patient if they have an existing denture. So if they have an existing denture and it is smooth, I would probably recommend to you to prescribe a smooth denture from the lab, to note that in the RX notations. Oppositely, if their denture is festooned and stippled, then I would duplicate that with their new denture. If it's an immediate denture, I tend to lean towards stippling and festooning. And if it's a patient that hasn't worn a denture in ages, but is fully edentulous, I tend to lean towards smooth. I was chairside with a delivery not long ago, and the patient was thrilled. The fit was fantastic. She's smiling in the mirror. She's smiling at all of us. She loved the looks of it. She's, chewing and talking and is super, super, super happy. And then she sits back for a moment, and I see her like run her tongue across her teeth. I was like, oh, it's stippled and festooned. I wonder what she had before, because I was not there on the appointment before. And sure enough, she had a smooth denture, and we ended up redoing it as a smooth instead of festooned and stippled. And she was much happier with the smooth denture. So I'd just like to share that as a, as a pearl for you to think of when communicating with the lab about your own patients. So let's talk a little bit about what that printing of a denture looks like. So this is printing of the base itself. It's really cool to see it happening live. And then the teeth are printed separately, but all in one piece. They're not individual teeth. And then they're luted together. So it's a chemical bond that's luting it together. This is that little teaser I was telling you about facial scanning. We'll get into that in January. You're gonna love it. It's really super cool. We're printing for overdentures as well, and full arch cases. And so let's dig into the prescription itself for the iTero. So this is specifically for a copy denture, but what I want you to pay attention to, what I want you to really notice, and this prescription came out over a year ago now. There is a procedure option, and under procedure, we're selecting denture removable. And then under type, we're going to select full denture tissue based, right? If it was an overdenture, we would select implant based. If it was for an immediate denture and the patient still had dentition, we would select immediate denture. Or if it was a partial or removable partial denture, whether it be a cast frame or a flexible, we would select partial denture framework, right? But for copy denture, we're selecting denture removable. And then we are going to select the next stage, right? So what do we want back? 9 times out of 10, I am going to select a Trian. And then you can indicate your shade, your mold, what shade of acrylic you want as well. There is a really cool mold guide, if you will, that auto-populates, and it is based off of Dentsply Sirona's original theory of taking the patient's shape of their face and inverting that, and that is supposedly the shape of the central. Now, there is an option, you'll see here where it says copy denture scan. So there's an option to click on that button to highlight that for the copy denture. And in doing so, it's sort of activating like a pre-treatment scan that I'm sure if you're iTero users, you're familiar with pre-treatment. So you're going to get 2 scanning opportunities for the operative arch. So let's say it's a maxillary denture that we're scanning for. Scan number 1 is going to be the scan of the existing denture that you're trying to copy. Scan number 2 will be of the edentulous arch. And just as in pre-treatment, scan number 1 is going to be green in the background. And then scan number 2 is going to be blue. And that's an example of both the scan of the denture that we're copying, as well as the intraoral fully edentulous arch. And I do not always scan the patient's fully edentulous arch. I attempt to, if it's a compromised patient, somebody with Parkinson's or it's just a more challenging situation. What I'm trying to say is I've had great success in not always scanning the fully edentulous arch as well. I would recommend contacting your lab about what their particular preference might be on that. And so then this is the live RX, not sort of blown up, right? So you see the select procedure as a denture removable, the select type, and then the stage. Also blown up for the mold and shade of the teeth, shade of the tissue. You're of course going to input a dental laboratory as well. And this is the reference denture scan, which I'm going to do one here quickly. Next is going to be the palate, then the buccal corridors, rolling over to the intaglio, at which time I'm going to stop the scanner, let it process, and then start it back up on the intaglio again. And we find that it merges the cameo and intaglio sections best that way. And finishing with that bilateral bite. And that is a screenshot of the wash impression. Right, here's some images there. And this is from the camera icon that you could mark and use this as a communication tool to send to the laboratory. And that can only be done right now through your myiTero.com account. It's a really nice way to communicate with the lab. Have a lot of offices that use it for partial designs as well. We've got some examples here of not adequate data, right? Those vestibules and flanges are missing. We've got great resources. Some resources from the presentation tonight. And then I'm going to leave this up for a moment and check any questions before I shift to
You have one,
my
Kelly.
iTero scanner. Yes?
It is what impression material colors does the iTero pick up well? And what colors?
I would say not pink and yellow. Pink and yellow is what was donated to me that day. It's okay. I really like blue and green. I think blue and green picks up much better.
That was perfect because then they were asking what to stay away from and what to use the PVS material in the reference step denture.
Got it.
We're being asked if there's a cost difference between analog and digital dentures. So I just want to share with the audience. We can answer any pricing questions offline. Feel free. I will post up Kelly's email to contact or the NDX education, and we can get you directly connected to a laboratory. ACE accreditation prohibits us from talking pricing during an educational course. And we've got some more. If you don't scan tissue, do you turn off copy denture button?
Yes.
And then is there a type of spray that contains a powder or something similar that makes scanning dentures easier? This shiny surface makes it rather difficult.
Yeah, there is. So the chemically, it is referred to as titanium dioxide. If you are familiar with CEREC dentistry, it is CEREC spray. It's the old CEREC spray, which is still out there on the market. And that can be used intraorally as well. But what you can spray the denture with, and there's got to be a better way to say it, but it's Tinactin foot spray. All right. You can buy it at any pharmacy. You're not going to use that intraorally. That would only be for spraying the denture itself. And the reason that can be helpful is that the glare, the shine that you experience in your operatory when you're scanning the denture. Sorry, I had to re-log back into my scanner. It causes light reflection. So that's why the spray can be helpful. So if you can create like a little shadow for yourself, make sure that the overhead light is off. Don't stand beside a window. Just sort of go into a corner and try to scan the denture. That would, in my opinion, work just as well as one of the sprays.
Wonderful. And then audience, I did post up the 2 flyers for the courses that are coming up. One is being taught by our very own Brenda Kirkin, Clear Aligner Therapy, Protocols, Procedures, and Practice Applications. That will be the last webinar as you normally experience NDX webinars, because then the second one that comes up, it is being launched directly out of our new platform, and I'll be posting up an image on that shortly. It is implant integration, basic and advanced principles, being taught by Gene Peterson, CDT. He is the Director of Technical Development Learning at Stern Gold, and we're excited to have him back. Are you up and running, Kelly?
Almost.
Okay, so then I'll go on and chit chat really quick and share my screen. So that way you can see we are introducing, oops, I'm going to move a menu. Introducing NDX Education. It is an all-inclusive education platform. You can see the sign-up steps to the right. It is easy. You just click on education.nationaldentex.com. Sign up with the information you used to entering in for every webinar. Now you only have to enter it in once. Accept the or read through the terms and conditions to accept, and then start your learning journey. The system will ask for you to verify your email address because everything does have to be coded to unique email addresses and persons, just like every Zoom registration. They ask that you complete the survey, how you hear about us, and then begin exploring this site. All right, I'm going to stop screen share, Kelly, because I can see you're up and running in the
I am
background.
up and running. Okay, so everybody can see my iTero screen, correct?
Yes.
Okay, so under procedure, I'm selecting denture removable. And then under type, I'm going to do full denture tissue based. I'm selecting a lab. I'm going to select a try-in. And my denture is a maxillary denture. And then I am going to scan. I did want to mention one thing, that if you do an intraoral scan of the fully edentulous patient and you think you got good data and the lab does not think you got good data, they think there was an opportunity for improvement or a better way to verify vertical, they may request that they send you a custom base plate with a bite block. All right. That's not a bad thing. That's an okay thing. That's a good thing because you can still take a watch impression inside of the base plate, then put it back into place, then verify vertical and either scan or put this in a box and send it to the lab. That's the digitally assisted part that I had mentioned earlier. I like to mention that because it's not a bad thing. Okay, so I am going to scan the lower arch. And again, it's always occlusal lingual buccal. And this is an articulated model. When I get to the midline, just with any full arch, when I get to the midline, I'm taking the wand out of the patient's mouth, but I'm leaving it on. I'm coming back to the opposite side, rotating buccally, coming back across, crossing the midline, and tagging back up on those incisal edges. Now I'm going to advance to the next screen, which is going to be the maxillary scan, which is going to be of the denture itself. So I'm holding the denture. I just blinded myself. And now I'm going to get that buccal flange. And in doing so, I'm coming up and capturing a little bit of that impression material, and then I'm coming back down and capturing a little bit of the buccal cusp. And again, it's pretty slow. It's methodical. And I'm going to switch to the other side. Make sure those anterior teeth all connect together. And then I'm coming over right around like tooth number 2. And I'm going to roll over. This is the most challenging part. So I'm going to stay in contact with that border. I'm going to roll over to the intaglio. And once I get to the intaglio, I'm going to turn the scanner off, right? I'm just going to turn it off for a moment. Usually I'm counting to like 5 in my head. You can see the image sort of move on the screen a little bit. So it's beginning to do some processing. And then I'm going to turn it back on again. And I'm going to scan again in the general vicinity where I left off for it to merge together with that original scan. So you can see we merged together now. Now I'm going to do the borders. And I'll fill in the rest of the palate. Now, if the patient has a very high voltage palate, it can sometimes be a little tricky to get like right behind the central. Sometimes that area can be a little challenging just due to the size of the head of the wand. Awesome. So let me turn that off. And then you would put the denture back in the patient's mouth and advance to the bite registration. And you would do a bilateral bite. And there you go. So a short example of the reference denture scan.
Kelly,
Any,
somebody's asking, will
yeah,
dots and lines help picking up the intaglio surfaces?
um, the short answer is no. From a R&D perspective with iTero, it's picking up topography, it's picking up lumps and bumps versus markings that we would put on the denture or on the impression material. The only time I use a transfer marking stick, a Dr. Thompson stick, is when working only on the maxillary arch, intraorally on the fully edentulous patient. That usually it's a patient that's worn a denture for 30 years and it's super smooth. Like there's no rugae definition, like it's really, really smooth. So I'll put some markings there just for my eyes to follow a particular path to help stitch the data together. Great question.
Great. Thank you. And do you encourage turning the scanner off before completing the intaglio portion of the scan?
Do I encourage so when I do the cameo, right, the tooth surface, I'm going to roll over to the intaglio just for maybe 3 seconds. And I turn it off to allow the processing of the data to begin. And then I start back on the intaglio. I hope that answered
Yes.
the question.
Yes.
Okay,
And
great.
then can a printed denture be realigned with a chairside realigned material?
Yes, it can. I should say ours can. We use Dentsply Lucitone print material for our premium printed dentures. And I know that you can use like CoSoft chairside reline material with that for sure.
Great. Thank you.
Of course.
That's all that's popping up right now.
Awesome. I'm going to, if there aren't any other questions, I'm going to stop my share. And would really just like to thank all of you for being here tonight, for staying on tonight. Please feel free to reach out to me personally if I can offer any type of one-on-one support, coaching virtually. We go chairside on occasion as well. So know we're here to be your partner. And thank you so much for joining us tonight. I really, if you can't tell, I'm very passionate about what I do and really enjoy doing it. And I couldn't do it without you. So appreciate you.